So we've added another unit and added another psychiatrist, added a nurse practitioner. I was an addition at the time a year and a half ago just to bring in more resources here.
Yeah, so on the one hand, we don't want people to have to come into the emergency department. On the other hand, what the crowding of psychiatric patients in emergency departments has done is highlighted and put pressure on systems to recognize the fact that there's a need out there. So you don't want to have to drive your business by, a need being that dire that people are willing to sit in the emergency department for days. At the same time, it has taken that, I think, and again, this isn't just our institutions, this is nationally, for people to realize, yeah, we got to do something about it. We need to create a situation where patients in psychiatric crisis can get the help they need in a reasonable amount of time. But we're sort of now playing catch up. So what is that a reflection of? Well, it's the fact they're not getting care other places. Which is the reason for talks like this, because it's a community issue. We have lots of meetings where we talk about what we're going to do, not just as our hospitals, but as community partners in this. We're also lucky to have a great community partner in our local Department of Mental Health clinics here in town. So Charleston, Dorchester Mental Health, Berkeley Mental Health. We couldn't even begin to address the needs of the community without the important work that they do. So what both of us do is we say, what are our needs? We say, well, how does that interface with not just getting patients well and discharging them, but discharging them into an environment where they can then stay well. That's easier said than done, but as a hospital system, hospitals more and more are thinking, my care of that patient doesn't necessarily end just at discharge. We need to make sure they get to where they need to go to stay well. So something that's new, will be new as of January. After several years of petitioning, we will have dedicated space in the ED at MUSC to care for our psychiatric patients. I'm looking at a former nurse who I used to huddle with every morning and talk about all the patients boarding in ED. They will be cohorted, all in the same place. So it'll probably be a variation of what you all are doing in that ED extension. But literally part of the ED, staffed with mental health trained nurses, social workers. We'll have psychiatrists that will be there embedded in the ED, and essentially ED psychiatrists triaging and directing traffic and assessing and admitting in real time. That sounds like kind of just adding a little bit of resources, but it's going to be a huge change in terms of how we do business, and our patients will get seen quicker, care faster, and get on the road to recovery faster. I expect that will work so well, it'll be slightly expanded when we open the new children's hospital. We're also looking at having nurses work with our patients after discharge. So, usually hospitals kind of stay within their walls, and we're looking at a couple different models of creating a team. Essentially, it'd be a variation of the ACT team that the Mental Health Center does. But we'd identify patients who are at risk for relapse and readmission, relapse from their illness and or substance use. Actually go visit them where they're living, help make sure they have meds, are actually getting to their appointments. They'll have a point of contact probably based in the ED to help troubleshoot from a clinical decision-making standpoint. And again, just sounds simple, but will make a big difference. And we actually have predictive models where we can, before we even discharge someone, fairly accurately predict who's at high risk of coming back in the next 30 days. We're doing more and more telepsychiatry. So we want to get people well and identify mental illness and treat it before it comes to us. So we're doing telepsychiatry to primary care clinics around the state, regionally, but across the state, for kids and adults. And we're now starting, in March, we'll be starting telepsychiatry consultation to inpatient medical and surgical units. So our facilities around the state that have no psychiatrists, and that's a lot of hospitals. So you have hospitals with 500 beds and busy EDs, and they have no psychiatrist anywhere in sight. There is a mechanism for them to get consultation in their ED through a program that Department of Mental Health runs in their emergency, so they can have their patients seen in the emergency department. Once they get to the medical surgical floors, they still need expertise to come in and help them manage ongoing crises and situations. And we both engage in a lot of outpatient services with the idea that we know, again, if we just get them well and wish them well on the way out the door, that's not going to help most folks. So we both run intensive outpatient programs where folks can come daily if they need to and check in with us, get additional treatment without having to spend overnight in the hospital.
From a doctor perspective, when you're treating in this setting, you get to know them maybe even the ED, then you admit them, you get to know their families, you spend time with them, you see them go to groups, you see them get better, you see somewhat of their more better, higher functioning personality come out. And I realized kind of early on, I was doing the discharge summary and doing the prescriptions, and I just felt blinded. I had no idea what they were going to experience. I knew what I would like them to do. You know, I'd like you to see a family therapist and a doctor within a week because you just went through this terrible crisis that we worked really hard to get you through. But I felt a little blind, and that's when I started reaching out to MUSC, the community mental health centers, which are excellent. Everybody's got their limits. And then Feder Clinic and some other resources in the area and private psychiatry. And just trying to get my head around personally, what is that continuum, what do I want, and what's available, and what can we do to improve it as a group, like, and what needs to be added on, what needs to be better understood, whether it's just communication or actually creation of new services. So, and another factor I think you can't ignore is the shifting climate of insurance. So you get Obamacare, which then dumps some people off Medicaid, so their benefits change a lot. And then some people end up with no benefits, some people end up with better benefits. That totally changes their access to care, their ability to pay for medications, which shifts which ones you choose. I mean, these are some of the things you want to be very aware of, but it's very complicated. It's really complicated for people with lower education that just don't want that savvy in the healthcare group anyway, or that struggle.
Well, and things can be changed at a very broad level. So there were some Medicaid changes that we had two-part intensive outpatient programs going for kids. And literally overnight, the reimbursement changes from Medicaid made it so that we had to collapse them into one and scale back, or else we couldn't operate those clinics. We can't, I mean, we have an obligation to provide services. We also can't run a clinic that loses gobs of money, or the hospital just says we can't do that anymore. So we had to scale down clinics to meet changes that came kind of out of nowhere, and that we always protest against these things, but usually once they're done, and then we have to react accordingly. And there's really, if a hospital system is advocating for changes or for changes not to happen for their one clinic, no one's going to listen to that. It has to be sort of a united front.
Right. Then access to medications, what we struggle with constantly is like the generic medications aren't available, the prices change a lot. This has a huge impact on whether people can get most of the people that come through at a level that need to be hospitalized aren't going to need to be on medication for some time. And that medicine can cost from $4 to $4,000, depending on how well you think about it or prescribe it or what day of the week it is sometimes. And you know, as a doctor, you don't always have time to look up every single medicine, and the social workers, case managers, everybody pitches in and helps out. But it's a lot to keep track of, and it is another, I think, barrier to care. So what are we doing here? The clear need was that they needed more beds. I mean, just needed more beds for emergencies. We were holding people too long waiting for a bed. They'd already been screened and cleared and given as much care as they could in an ED emergency setting. So we were able to get permission and converted one unit into non-additional beds. That has helped. That has less people in our behavioral emergency department center in general. It's still full, and all the beds are always full and needed. They're currently doing emergency department renovations to have a better, safer space for psychiatric patients eventually. It's like a 3-year process of renovation. This does not happen overnight because it's complicated, but it's happening, and part of that is to accommodate what the needs of the community are, including behavioral health. There are plans and pre-approval, and it's in the process of building a 60-plus bed facility in this area. So that would be a freestanding psychiatric hospital, essentially, with a broader variety of services, hopefully to complement what MUSC is trying to do and to grow in what the area needs. There's some I think it would include an OP and some community services in it as well, because that's also a need in this area, similar to what Dr. Kluwer was talking about is happening in USC. So we're very excited about that because that will actually serve a big part of the community and could be a very interesting part. It's still early and there's not even a date of exactly when that might open, but I'm encouraged by that, and that could really help with the continuum of care here. We're adding community telepsychiatry to be more available in EDs, including just similar to what they're doing in some of the smaller rural EDs that have no access to mental health, and also really just trying to get people in front of a psychiatrist faster, so they're not just waiting just to see any kind of psychiatrist, period. Telepsychiatry has improved to the point where it actually works and it's easy. It's not as onerous as it used to be. Expanding other outpatient services, I'm working with some other hospitals that are actually adding outpatient clinics to serve people that are frequent utilizers of our hospital, that don't seem to be able to sort of sink in with some of the current outpatient services that maybe we could do in a different way. As an extension of our intensive outpatient and step-down services. We're working constantly on strengthening community collaborations with things like Today and working with community mental health. Trying to work with the state hospital and other state resources just to understand what they need and see what we can do to help them and what they can do to help us. And then integrating graduate medical education is happening in some other areas with HCA, not necessarily here, as this market is smaller, but what HCA is finding is that if you can integrate some residency training programs in different areas, then you can actually offer more robust services. That just brings more resources around, more people. We're opening another behavioral health unit in North Grand Strand, which is, I guess, an hour from here, like all in. So that will help somewhat with the area